adult or in for us is basically repair. It's no longer regeneration unless it's very minor injuries, such as just injury inflicted on the epidermis, for example. That can regenerate. The epidermis can regenerate, but if it's deeper than that, then you will guaranteed to form a scar instead of a normal looking tissue afterwards. Okay, so just to go through a bit about wound healing, I'm sure most of you, or if not all of you, have read about wound healing. It's a dynamic and overlapping phases. You have hemostasis and inflammation, then you have proliferation and remodeling. Okay, so going through a bit of those processes. Hemostasis, once there's an injury, you're going to have some blood loss, so your body will react by trying to control the blood with a transient vasoconstriction and then form a plug to prevent further blood loss, and this is in the form of platelet and fibrin clot. It involves the platelet and coagulation system. I'm sure you know, or you can read about the pathways of coagulation, the intrinsic and extrinsic pathways. So extrinsic pathways involve the tissue factor and factor 7, and intrinsic pathways involve factor 9, 10, 11, and 8. And both these pathways basically activates factor 10, which then converts prothrombin to thrombin, and then thrombin converts fibrinogen to fibrins, and then form the blood clot. Okay, now this blood clot has several functions. One is as a plug to prevent the blood loss, and also serves as a matrix for other cells to go into the wound. For example, inflammatory cells and stem cells. So, and also contains cytokines and growth factors to regulate the cells. So the second phase is inflammation. So once the initial vasoconstriction stops the bleeding, then you have a vasodilatation, which is mediated by the histamine and prostacyclin, and it increases vessel wall permeability, which allows all these cells such as neutrophils, macrophages, and fibroblasts to pass through to the wound from the vessels. Okay, and then the neutrophils' main action is basically to clear the debris and also phagocytose the bacteria, and this happens within the first 24 to 48 hours. Next, the main cell or predominant cell during this phase is the macrophage. As you can see in the diagram, it has lots of function. It's, not just debridement and antimicrobial action, also is the driver for the next stage, which is the proliferation phase. Okay, because it secretes mediators and cytokines that attracts fibroblasts and also induces angiogenesis and other growth factors. Okay. Proliferation stage usually starts within a couple of days or after the third day, and it can last up to about 3 weeks. And then the predominant cells during this phase is the fibroblasts, and the major component of the phase is fibroplasia, which is collagen deposition, angiogenesis, wound contraction, and epithelialization. So we'll just go through those different stages. So fibroplasia, as I mentioned, the macrophage is responsible for attracting the fibroblasts by the PDGF and tumor growth factor beta. And fibroblasts' main action is to produce collagen and ground substance, and the formation. And during this phase, there's formation of the extracellular matrix. Okay, in the diagram, there you can see other role of fibroblasts during the wound healing. Okay, and the other thing that happens during the proliferation is angiogenesis, which is the formation of new blood vessels, which is basically characterized by the formation of granulation tissue. Okay, and then you can see the appearance of this moist, shiny, hyperemic red granulation tissue, which suggests that it's a good wound healing, or it can be pale or friable, which suggests that that's not the process not very good or a poor wound healing. And then wound contraction. The aim is to render the wound smaller, and is the action of myofibroblasts, and it begins about 1 week, and usually, well, it completes until when the wound is completely closed. Okay, and the last stages during this phase is epithelialization. It begins once the wound is filled with granulation tissue, and basically it's mediated by keratinocytes. And you can see that this is the thing that you look for when you look for a healing wound. You look for the sign of epithelialization. If it's not, or if you don't see it, that means that there's something wrong with the wound, or whether maybe it's still in the inflammatory phase, so that you need to do something or intervene. For example, if there is suspect infection, then you need to culture the wound and basically treat the infection. Because if the wound is healing properly, or is in the right direction, you will see epithelialization taking place. So it serves as a clue that you are doing the right thing. So the last phase during wound healing is remodeling, and usually begins about 3 weeks after the injury and can last up to 1 or 2 years sometimes. Okay, and the aim is to basically replace those granulation tissue that was formed before with avascular scar tissue. Okay, and the capillary will start to regress. There's no net collagen increase anymore, and the reorganization of the haphazard collagen to a more organized collagen bundles, and the collagen which was during the wound healing is predominantly type 3 collagen will be replaced by the normal or more, well, a stronger type 1 collagen, as in normal skin, which has 4:1 ratio of type 1 to type 3 collagen. Okay, there are other types of collagen, which is, but the predominant one in the skin is a type 3 and type 1. As you can see, if you look at the table there are about 21 types of collagen in different types of tissues. So just to recap, the graph showing the stages of wound healing is, as you can see, it overlaps and is a dynamic process. So if something's wrong, it can shift to the left again, or if you're doing it right, it will shift to the right. Okay, so you have the inflammatory phase, the proliferative phase, and then the remodeling phase, and then the processes that go through during these phases. A bit about scars. So repair of the wound, and you will inevitably produce scars. And there are wide variation of scars. So you have in fetal wound, obviously, is scarless, as I mentioned, because it's a true regeneration in fetus. But in us, you have either fine linear scar, which is the preferable one. You have widespread or stretch scar, atrophic scar, contractures, especially in burn scars, and hypertrophic or keloid. Okay, so the picture just shows a severe form of burn contracture scars. This is hypertrophic scars. It's, you probably know how to differentiate between hypertrophic and keloid. It sometimes looks the same, but the few differences that you can establish is that the scar for hypertrophic is limited to the wound, original wound, and if you give it time, maybe 6 months to a year, it will eventually regress or becomes less prominent. Whereas the keloid will never regress or rarely regress. It's a bit more symptomatic than hypertrophic. It can be painful and itchy, and there's usually a genetic or race factors involved. So if the patient has had scars previously, you can look at them, and if they have a genetic predisposition, they will develop keloid. So all this patient, if they are undergoing surgery, you really have to warn them of the possibility of developing keloid. Okay, unfortunately, at this stage, there is no cure for keloid. There are steps that you can take to reduce the keloid, but there's at the moment no cure or proper treatment. So a bit about stem cells, since this is what scientists are working very hard to get at, basically to be able to regenerate damaged tissues. So the answer probably lies in stem cells, because basically you want to stem cells have this regenerative potential, and it can basically, in theory, produce whatever's being lost or damaged. There are two broad types: the embryonic stem cells and the adult stem cells. Okay, the stem cells properties are they basically are able to self-renew without differentiation, and they can basically turn into any type of cell. So, and that superpower, I suppose. And there are different different types of stem cells. You have a totipotent, which is basically the highest form, and this form basically can form all cell types, including extraembryonic or placental cells. Basically, it can form a new organism. Totipotent cells is basically cells that are taken from the first few division, or once the gamete fertilizes, the first few division of that, those cells that are extracted from those cells, the what do you call it, the morula, or that thing after the fertilization, those are the only cells that are totipotent. After that is no more, there are no more totipotent cells, because the next one is basically pluripotent cells, which can form all cell types of the body, but they can't form a new organism. So it still have less capability than a totipotent cell. And the last one is the multipotent, which can form more than one cell type, but is less than pluripotent. There are also, scientists have also discovered that they can actually induce cells from the tissue, any type of tissue, they can induce it to become pluripotent using some technology by introducing transcription factors into the cell using the virus gene or something. I'm not into all this technical bit. You can obviously read up on it. Basically, they can take cells and basically induce it to become pluripotent. Okay, as shown in this diagram. So the good thing, the advantage of this is that you can basically take any somatic cells, which is any cells of the body, and then reprogram it to become pluripotent. And then theoretically, you can basically generate any type of tissue: skin, nerves, fat, muscle, bone, anything. Okay, so that's what the research are going to at the moment. But the advantages of this is basically it avoids the ethical conflict of taking stem cells from the embryo. It's non-invasive, and you can basically implant it back into the patient, so there's no problem with rejection. And you can derive many different cell types, for example, fibroblasts, keratinocyte. The disadvantage is, or what's limiting it, is basically the cells have very low reprogramming efficiency. So it's basically it's not as easy as it sounds. Okay. The common stem cells that are available for us at the moment, basically two areas: bone marrow. We know that the bone marrow stem cells contribute to lots of different tissues, including the skin. So, example, keratinocyte or fibroblast, as well as contributing to cells for the inflammatory process, like the neutrophils and macrophages. And it has been shown in studies that the cultured bone marrow-derived mesenchymal stem cells have been shown to promote healing of diabetic wound and burn wounds. Okay, so they've done research on this, and the stem cells do actually promote healing. Another source of stem cells is adipose tissue, which has also lots of capability to differentiate into all or most type of tissues, and has been shown in animal model at least to enhance wound healing. However, our understanding of the exact mechanism of the stem cells is still lacking. There might be a role of platelet in the mechanism, but basically research is still ongoing. So at the moment, we still don't have the answers or the easy way to basically regenerate all these tissues. Okay, might be in the future, I don't know. Okay, any question on that?